Welcome, everyone, and thank you for participating in today's Get the Medications Right Call for Member Feedback webinar. My name is Katie Capps. I'm the co-founder and executive director of the Get the Medications Right Institute. I want to start by congratulating the Institute on an important milestone. In just over 18 months, the Institute has grown to over 1,150 members, representing over 750 companies throughout the country. This membership has been invited to participate in a series of member feedback webinars over the past 2 weeks. In total, we've had over 470 individual members register for these events. Each of these events highlights steps to be taken for medication management reform in one of 4 key areas: how we use diagnostics, how we integrate technology, how we pay, and how we practice. In July, we released the Blueprint for Change. It's a robust report that outlines how multi-stakeholders can offer input and guidance and feedback on the way medications are used. It's our roadmap for reform. If you've not read it, please go to the website and download a copy of it. Before we begin, I want to thank our board of directors. They offer strategic guidance to the Institute and also serve as sponsors for one of our many work groups. I also want to thank our executive members, our strategic partners, and our founding funders of the Institute. And finally, I want to thank our staff. We are a small but mighty team. They work hard, and because of them, these activities are possible. In addition to that, I want to thank our many work group leaders. Those leaders, several of whom you'll hear from today, are instrumental in offering guidance back to the market, and we are very appreciative and thankful for their support of the Institute. Now, just a few housekeeping tips. If you run into any problems during the presentation today, please contact Natalie Cromwell. She'll be glad to walk you through any troubleshooting that's necessary. All participants on today's webinar will remain on mute. We ask you to submit your questions or your responses to the questions that we ask you as an audience in the chat box. As the moderator, I will ask you, the audience, 2 or 3 questions per session. So when you respond back in the chat box, please note question 1, question 2, and likewise. We will use that feedback both for discussion during the Q&A session, and also we will use that as information to send back to the work groups as we look at establishing the direction of those work groups. How we practice is important. You know, prescription drug spending exceeds $300 billion a year. And while affordability of the drug product and access to the drug product has been at the height of discussion nationally, we believe through an institute that what is also important is how we deliver these drugs, the service component. To do this, we need to pay for a process of care or that service to ensure that medications being taken are appropriate for that individual. Medication selection and management matters. Our goal at the Institute is to align payment and policy to reward for a process of care that will help all of us answer, is this the right medication for this person? We believe that optimizing medication use through comprehensive medication management and practice is the way to achieve that goal. Comprehensive medication management is a service that can be delivered across the continuum of care and through different modalities, either face-to-face, telephonically, or through telehealth. Our Practice and Care Delivery Transformation Work Group, including the Evidence-Based Resources Subgroup and the Best Practices and Innovative Solutions Subgroup, have been hard at work creating guidance and tools to expand access and adoption of these payment solutions to inform how we practice CMM. I want to thank them again for their hard work. Our first round of presenters today are Marcia Mugg, who will be presenting for the overall work group, and the leads of the evidence-based resources subgroup, Sean McFarland, Heather Orr, and Curtis Haas. They will all give brief updates on the work group activities, and then I will facilitate our first member feedback session. I'll now turn it over to Marcia.
Thank you, Katie. I'd like to start by acknowledging our other executive leads, Julie Gropey from the VA and Casey Thompson from ASHP. Our work group has two subgroups, as you've heard Katie describe. Later in today's session, you'll be hearing from the Best Practices and Innovative Solutions group. They're developing some use cases and marketing strategies to demonstrate the role of CMM in optimizing medication use and improving patient care. This group is creating unique tools that are specifically targeted at different stakeholder groups, including physicians and other members of the healthcare team, as well as payers, employers, and most importantly, patients. We'll start off this session by hearing from the evidence-based resources group. GTMRX members in this group have undertaken a thorough review of the current CMM literature to identify those studies that best demonstrate the value of CMM in achieving the quadruple aim of healthcare. They've also described gaps in the literature that are going to require further research, and are also working to define the optimal metrics for demonstrating the value of CMM. And with that, I'll now turn the presentation over to Sean McFarland.
Thank you, Marcia. Thank you all for joining today and giving me the opportunity to update for what our group has done. I would be remiss if I first of all did not thank the members of our subgroup and actually the evidence-based resource group as a whole. We have had a wonderful time exploring this, and I could not have asked to work with a better group of colleagues. So you'll see the members that are there, and we'll go through our charges. Next slide, please. So our group embarked on a very ambitious claim. We first started to look at all the literature that was surrounding comprehensive medication management. Our goal was to develop a library of evidence-based resources to be used by you for a variety of stakeholders, which would allow team members and stakeholders to understand the value of CMM, specifically focusing around the quadruple aim of healthcare. So what have we done over the past 6 months? We've done a lot. We've offered proof points and evaluated peer-reviewed evidence showing the value of CMM on the quadruple aim by thoroughly evaluating the primary literature. We evaluated the literature using a measure of fidelity among all members to make sure that the articles that we were offering in our document were consistent with the way that CMM should and has been practiced. We wanted to develop the evidence document, the outcomes of implementing and integrating comprehensive medication management and team-based care, a review of the evidence on quality, access, and cost, which is what we will show you in just a second. So what have we learned? First of all, and I think all of our group would agree, CMM literature is increasing quickly. Traditionally, when we looked back at the older articles, we would see a lot of disease state management articles. We would see less articles focused on patient satisfaction and provider satisfaction. We're seeing those increase to treat the totality of the patient exponentially. And we also have seen that value exists with CMM implementation regarding the quadruple aim, and this evidence-based resource document will support that statement. Next slide, please. Charge 3 is we had a smaller group that evaluated the need for a review of the current available CM literature focused on the quadruple aim of healthcare. And what we've done, our group has written and summarized the CMM literature into a concise review focused around the foundational components of CMM, the impact of CMM on the quadruple aim, and the gaps in CMM literature. And we're excited to say that we've completed the paper, and as of last week, the article was accepted for publication in a major journal that we won't disclose right now, but we will be excited to release that when it comes to fruition. Next slide. This is the evidence document that you'll see. If you haven't been to the Blueprint for Change Resource Center, please go there as soon as you get through this presentation. But that's the evidence document, and you'll be able to review that at your leisure. Again, how can this be utilized? We're hoping that you evaluate the CMM literature to build your case for implementation of CMM, whether that be around quality or cost or patient or provider satisfaction. We're hoping that you evaluate all four, that you can develop your case to be able to do that. And you can design a CMM practice that it's focused on the literature and maintains a measure of fidelity around a model that can be replicated at multiple practices. Next slide. So what are some opportunities as we move forward? We want to continue to evaluate the literature and add literature as it's published. We want to look at literature that's based on the fidelity model of CMM. As we add primary literature, we'll remove literature that is more focused on disease-specific interventions, which we're excited about to look at the totality of care. We want to develop an easily searchable database using search factors. I will say that selfishly, sometimes we go in and hit the Control F, and if you're looking for cost or quality, you can search that database to be able to find, or search that document to find that. But we want to develop an easily searchable database. And last but not least, we would like to put the articles in chronological order to be able to allow the end user to evaluate the most current literature as it presents. And we'll be updating this document biannually. So with that, I will turn the presentation over to my colleague, Dr. Heather Orth.
Thank you, Sean. I have had the pleasure to serve as the lead for the subgroup working on Charge 2, which consists of all of the individuals that you see listed on this slide. They've been a great group to work with, and I thank them all for their valuable contributions. Charge 2 was to determine future needs and gaps for CMM research, as well as needed tools based on the evaluated library of evidence and the role of GTMRX to close the gaps. Specifically, this related to evidence for the clinician or practice implementing CMM into practice and redesigning or strengthening their current CMM practice, as well as the foundational evidence needed for stakeholders such as payers or healthcare leaders to understand the value of CMM. Today, we'll share with you what we've learned through the process of reviewing the library of evidence as it relates to those gap areas that exist, and also the group's recommendations on actions to close those gaps. So next slide, please. You just heard from Sean regarding the work of Charge Group 1 in developing a library of evidence-based resources to be used by a variety of stakeholders. This library served as the source for our evaluation. Once we were able to note the areas where there was good evidence in the literature, we worked to identify the gap areas that exist, and in turn, those areas where additional research focus is needed, along with potential tools to address the gaps. We wanted to make sure the recommendations would work to inform multiple stakeholders, including health plans, employers, and consumers. We had a good deal of discussion and diversity of thought that went towards developing our report. One of the key insights we gained during this process is that there are multiple perspectives to consider when determining gaps and effective strategies to close those gaps. There were 5 general areas pertaining to the evidence around CMM that became apparent, and we grouped our recommendations accordingly. These areas of focus included establishment of value, care delivery, patient experience, clinician experience, and technology. Next slide, please. The primary tool developed by our group was a report that outlines not only the current state of the CMM literature, but also the gap areas that still exist. For each of those areas identified, we have also provided recommendations on approaches to close the gaps. It's organized in the 5 thematic areas that I just mentioned on the previous slide, with corresponding recommendations inserted for each section. Our hope is that these recommendations may be used to inform future research study design. This tool was developed in an effort to apply to multiple audiences, which include individual CMM researchers, professional organizations, along with their associated research foundations, and colleges of pharmacy and residency training programs as well. Next slide, please. We see multiple opportunities moving forward, and one of those is socialization of the document with appropriate stakeholders. It may prove to be especially useful to those entities responsible for building research agendas, which could include research foundations associated with professional organizations. Those responsible for training future researchers could use this as a guide to help ensure our future researchers have the foundational skills to be able to perform the needed research and are really aware of the questions that still need to be answered. It's also our hope that those actively performing CMM research will use this to guide future research and study design as well. There are still opportunities to develop additional tools for researchers that outline standardized language definitions and essential elements for study design measures across multiple practice settings. Resources should also be developed that outline methodologies to facilitate a broader measurement of patient satisfaction and engagement along with patient-centered outcomes. At the end of the day, to move CMM forward, fidelity to strong, valid research designs and the process itself is essential. So with that, I will turn things over to Curtis Haas.
Curtis, you're on mute.
I apologize. Thank you, Heather. I was muted. I would like to thank our subgroup, especially John Armistead, who's been the co-lead on this charge, and an outstanding group of colleagues that have really contributed to our effort. Next slide, please. Since we started working on this in July, we have worked to identify classification structure and how best to use metrics for looking at quality and outcomes in CMM practice settings. We've reviewed the relevant literature concerning what measures have been used in evaluating CMM practices to date, as well as looking at consensus-based outcome or quality measures and indicators. We've identified a subset of metrics or measures that we feel should be recommended for use with CMM practices, and we're actively in the process of drafting our report, which will be completed in the next few weeks to address our charge number 4. The insights that we've gained through this process is that at this time, the evidence defining and validating process and outcome measures specific to CMM practices remains limited. And given the early stages of CMM, that is not surprising. The variance in CMM implementation or lack of standardization with CMM interventions has likely contributed to some of this limited data. Most of the reports that are in the literature that have looked at clinical outcomes have primarily focused on surrogate or intermediate outcomes like A1C or blood pressure to evaluate clinical impact, and that needs to evolve, obviously. Well-defined economic and humanistic measures are generally lacking, and the most relevant outcome measures will be practice environment sensitive. That is, there's not going to be one set of measures that are going to fit all practice sites, but rather we need a selection of potential measures which may be most relevant to individual practice environments. We also believe that at this time there will be considerable reliance on consensus-based measures given the work that's been done to validate some of those measures. Next slide, please. Tools that we're in the process of developing or have developed to support our work include the currently being developed draft recommendations for CMM-related metrics. The thumbnail that you see on this slide is the first page of the outline of those recommendations. We have identified a list of recommendations for potential measures to be considered by CMM providers. And we also have an executive summary which will accompany those final deliverables. The way we foresee these tools being used is to assist individual providers, practice sites, or healthcare systems in choosing relevant metrics to evaluate the value of CMM practices, and also to help define the gaps in current knowledge for future research and the development of consensus measures. Next slide, please. The opportunities for this group as we move forward is to continue to scan the literature for advancements in CMM metrics and update the resources as needed, and to define future directions for CMM metrics. And this should include a strong emphasis on patient-reported and patient-centered outcomes measures. Thank you very much. At this time, I'm going to turn this back to Katie Capps, who's going to lead the next session. Thank you.
Thank you. Thank you so much, Curtis. Those were very informative presentations from our first set of speakers. I'd like to ask you as an audience, while I am asking other questions of our speakers, to respond back in the chat box to the 3 questions you see listed on the screen. Member feedback is extremely important to us, and it is certainly important to the leadership of the work groups and the participants in those work groups. So at this time, for those of you on the line, and I think we have several, if you would respond back in the chat box and note your response to Q1, Q2, or Q3, and respond back to everyone in your response. In addition to that, if you have questions of the speakers, please send those as well. The other thing I'd like to mention is in your reminder emails for this session, you should have received a example of the tools that each one of our speakers has outlined during their presentations. They're in draft form, and they will be released at the end of November. The 1st of December, we'll roll out release of all these very important guidance documents, the ones that are available for public use. But you should have also received a copy of those in your reminder email. So you may want to go back and reference that and click on the link in your reminder email. So with that, let's go through a few questions that we have for speakers, and then we will move on to our next set of speakers. Sean McFarland, the first question is for you. The evidence document outlines and highlights CMM in practice, showcasing peer-reviewed information that clearly shows how CMM leads to better care, lower cost, higher physician satisfaction, better patient satisfaction. From your standpoint, and this is the second evidence document that you have produced. This is an expansion of the June evidence document that you and Marcia had produced, and you brought in additional peer-reviewed literature. What were the 3 key takeaways from both of these documents, Sean?
Sure, and I think Marcia will echo what I'm about to say. You know, the thing that I took from those documents, the 3 things are: number one, I don't think there's an argument that implementation of CMM can improve quality, cost, and provider satisfaction and patient satisfaction. I think that ship has sailed. So, you know, as we get into evaluating the literature, that is an opportunity that I don't think is debatable. The other opportunities that I've learned from looking at this document is that it's just been impressive over the past year to 2 years about the literature that's being produced that has fidelity to the model. I think that we all would agree what has impeded the ability to evaluate overall outcomes related to CMM is the comparison of apples to apples. When you look at one healthcare site compared to the other, there will always some differences. But now literature is being produced that is comparing same to same, which is encouraging for payors, for healthcare practices to know that when you implement a model surrounding fidelity, and you've heard that word a lot today, that you can achieve better care, better cost, patient satisfaction, and provider satisfaction. And the last thing, I'm sorry.
Okay. Go ahead.
And the last thing that I would say is we focus so much on outcomes data related to quality of care. And it's been encouraging to see the increased focus on provider satisfaction and patient satisfaction in the literature. So those are the 3 things I think that we've taken from that EBR document.
Thank you, Sean. Marcia, did you want to add anything to that?
I'm in agreement with Sean.
Okay, thank you. Thank you. Heather, Sean brought up the importance of fidelity of practice, and I know you spoke to that in your remarks and your comments. What are the most common similarities among practices that are doing this right? High fidelity practices that optimize medication use through CMM in practice.
Well, I think Sean touched on a lot of the elements, but I think what's important is that the same comprehensiveness to the care that's being delivered. You see that in some of these models that are getting it right, that the care is the same, no matter which provider on the team is providing it, the patient gets the same services and the same broad comprehensive medication management. And I think also having those team-based care elements in place and everyone being clear on the roles of all of the people working together on the team is really important for those that are successful in doing this.
Right, that interprofessional team is certainly important. Curtis, the next question goes to you. Employers as health plan sponsors and their medical carriers struggle with how to measure and basically evaluate comprehensive medication management services and define value for key services like CMM. What are the three things that you think are important and they should be most concerned about in considering implementation and measures to ensure quality and value?
Sure, thank you. I think that you want to rely upon the three major factors that the National Academies of Medicine have outlined. And first of all, the measure needs to be valid, right? In other words, there has to be reliable evidence that supports the relationship between the measure and what it is you're trying to measure, and that is, the quality of the outcome or the process that you're trying to measure. So validity is very important. Secondly would be feasibility. You have to be able to implement the measure in a way that you get reliable data, that it's efficient and effective at being able to collect that data. It can be incorporated into practice. And lastly is really around action. Is it actionable? Can the data be used to inform and move process improvement forward? Can the results be used to improve quality? And I think those three, validity, feasibility, and actionability are really the three most important things to consider when thinking about implementing a measure.
And we certainly look forward to the recommendations that your group will have as it relates to that as well. Sean, the next question goes to you. My C-suite is really focused on establishing a CMM practice, but needs use cases that will offer insight into the process and the benefit of CMM in practice. What's the best way for me to use the evidence document to show that?
Absolutely. I think the next presentation that we hear from our other colleagues are going to talk about use cases and opportunities. So I think you're going to smile when you hear that presentation. Based on past experience, I think it's important that you understand, and we designed the EBR document to allow you to evaluate the needs of your C-suite or your team. There are some C-suites we're hoping that are focusing on all of the issues surrounding the components of care: quality, cost, patient satisfaction, and provider satisfaction. However, you can use that document to search and to be able to find that important component that you need to utilize to develop your use case, whether that be in this time, if we see a lot of provider burnout, we see people struggling specifically in primary care to keep up, so you can look at the information related to provider satisfaction and how implementation of CMM improves that opportunity for the provider. So we're hoping that you can tailor make it. Again, we hope, or I would hope, that your C-suite or your leadership is looking at all those components. However, if there's one that your facility or your healthcare system is focusing on specifically, you can tailor make that EBR document to evaluate the specific literature that provides validity, as Curtis had said, to be able to implement a CMM practice surrounding that specific reason that you're evaluating.
And you've certainly seen that, I think, within the VA system. So Curtis, the next question goes to you. You know, we manage and often reward what we measure. What do you think are the top priorities in managing CMM in practice?
I would say probably three things that are very important. I think, first of all, we need to be able to measure and manage improvement in medication-related outcomes. We know the literature, we know what it says now, that we're not getting great value from a tremendous spend on medications in this country. And from a payer's perspective and from a patient's perspective, how do we improve value from medications, and most importantly, how do we measure that improvement? Secondly, I think economic measures are important. You know, how will CMM impact overall utilization of medical services? And we know from Sean and Marcia's work that there is good evidence in the literature that CMM practices will affect those economic endpoints, and we need to continue to refine and improve our ways of looking at that. And then I think, in my opinion, the third important thing to look at is around patient satisfaction. You know, what are patients reporting as their improvements in the experience in their medical care due to the implementation of CMM practices and improvement in their drug-related experiences. So I think those satisfaction measures are extremely important. So if I had to choose three, those are the three areas that I think we need to focus on the most.
Thank you, Curtis. Thank you. And of course, those of you listening, I think, recognize immediately the interrelatedness of the work done, not only by this work group, but also the other work groups we have within the Institute in terms of the value and the benefit of cross-informing those activities. The final question, Sean, I'll ask of you, and then we will move on to the next set of presenters. From your standpoint and your subgroup standpoint, what are the three most important results or real-world evidence that a practice can take away from the evidence document that you guys have produced?
Thanks, Katie. It's a hard question to summarize everything into 3 points. I think the first and foremost, I'll say this again, is when we're looking at quality of care, implementation of CMM, when we're using a model surrounding fidelity of what the primary care literature says, there's no doubt that it improves quality of care of the patient. From any metric that you look, integration of CMM, whether it be decrease in hospitalization rates or specific disease state measures, it's improved. The second thing, and it's a second and third thing, because I think this is a huge gap that Heather's group identified, and what Curtis is talking about is looking at satisfaction, looking at patient satisfaction with CMM, and looking at what providers are saying relating to satisfaction. So those three things, quality of care, which again, that ship has sailed, we know it works, but continuing to evaluate and look at the satisfaction relating to CMM from the patient's perspective, which is the most important, and then the provider's perspective of the value of implementing this practice or this care model into their team.
Okay, thank you so much. We have one final question, Curtis, I had not expected, but how can one get involved in the process of developing the measures and supporting this work? And I think I can answer that. We require of all of our work group members that they are signing members of the Institute. If they have special expertise in a certain area, we encourage you to reach out to us, let us know, and we will share that with the work group leadership. Curtis, did you have anything you wanted to add to that?
No, I think you said that very well, Katie. Thank you.
Oh, all right. So now we'll hear from our second round of presenters from the Best Practices and Innovative Solutions subgroup, Julie Gropey and Amy Brooks. They will both once again offer a brief overview of the work that their work group has been focused on, and then I'll facilitate a member feedback session as part of our discussion after their formal presentations.
Great, thank you very much, Katie. And we're really excited to share with you some of the work of our Best Practices and Innovative Solutions subgroup. I have to thank my colleague, Dr. Hager, as well as all of our colleagues that participated on this group. As you can see, many of these individuals have been practicing clinicians or leading charges within their own facilities, organizations, and health systems in supporting CMM care over time. One of the things that our group first tried to do with this Charge 1 was to develop evidence-based CMM use cases that really embodied some of the patient-centered and team-based care and the role that our pharmacists play as a part of that care. Next slide. So in doing this, we had to take a step back and take a look at really what use cases already existed in the literature. We tried to showcase some of the practices from both private and public sector that really successfully had implemented CMM practice already. We used the evidence-based literature review that was done by our colleagues and subgroups by the evidence-based research group and tried to identify case examples which focused on a specific patient population. And doing so, we try to highlight many of the CMM success factors over time. One of the things that we gained and in insights as we were looking through these use cases was that oftentimes the literature describes CMM practices using differing terms. You might see terms such as medication therapy management or collaborative drug therapy management. However, the programs that were selected for the use cases really represented nearly every asset of CMM. It was also important as we were going through and developing these use cases to try to focus in on a particular patient population that our pharmacists were managing as a part of the team, especially as clinicians. The focus area that we chose was a primary care patient population because this was something that was very important to our employers, payers. Looking at pharmacists and physicians and nurses managing some of the common primary care conditions, such as cardiovascular disease, diabetes, as well as pain. Next slide. So in doing this, we created several tools, and I hope that you had a chance to go ahead and look at those tools. The first thing we had to do was develop a use case template or framework to really try to define all the key information that you would want to pull from these use cases to become successful with your own. These use case templates outline organizational details of the program. They provide a brief history and the scope of services provided, as well as describe key results and achievements, focusing in on that quadruple aim, the way that the team works together, and patient referral price over time, and how the pharmacist works as a part of the program. 4 use cases were actually developed using this primary care focus area. And you can see the example here on the screen for health partners. We also created use case examples for Minnesota Health Fairview, Kaiser Permanente Northern California, and a rural clinic in East Hawaii Health Clinic. Now, we intend these tools to be used together with the marketing strategy to our stakeholders. We know that there are common elements that can be extracted from these use cases that may be similar based on the stakeholder that we're trying to focus on. So our goal will be that these use cases are a broad compendium of research and resources that will be relevant to a large number of organizations and payers. Next slide. So as we move forward, we're working to identify additional focus areas that try to emphasize how medications can be optimized and really what the need is. In some of these areas, we've explored things such as the important role of pharmacists in transitions of care programs, the need for polypharmacy and trying to manage many of the poly problems, whether it's polypharmacy, polyproviders, how to try to navigate the system, especially for our geriatric patients. And then also looking at areas for how successful programs have integrated the pharmacist into high-risk populations, such as those with cancer. We plan to merge these use cases with the marketing materials that my colleague Amy will talk about next to develop a complete resource that'll be used for the different stakeholder organizations and payers. And with that, I'd like to hand it over to my subgroup lead, Dr. Amy Brooks.
Thank you, Julie. It's my pleasure to present our work over the past 6 months or so. As you can see, I have a very talented group of colleagues here joining me in this Best Practices and Innovative Solutions subgroup Charge 2, and a very talented co-lead in Dr. Mary Roth McClurg. Next slide, please. We started our work in this subgroup by focusing on the key things within our charge. So we were asked to develop a marketing strategy for key stakeholders by leveraging evidence-based best practices in CMM. And so really the beginning of our work was trying to come up with a comprehensive list of stakeholder groups and stakeholders within those groups. And then really we spent ample time discussing and debating what are the most important outcomes of interest to each of those key stakeholders. We developed from this what we termed our marketing matrix, and this document has really guided our efforts so far, and we believe will continue to guide in the months to come. We also have been fortunate to be able to interact with the employer toolkit group and really develop a much deeper understanding of the concerns and questions that self-insured employer groups in particular have as it relates to medication optimization strategies and comprehensive medication management. We've gained a lot of insights. First, although it was obvious to us that stakeholders care about different things, when we really spent time discussing it, it became more obvious to us that most things that exist currently discuss comprehensive medication management and medication optimization in general terms, focusing on a global audience, all aspects of the quadruple aim. And really, we sought to develop marketing content that was really stakeholder focused and stakeholder specific. We also learned that stakeholders really want to see outcomes in their own population or in a population very similar to their own before they're compelled to act on that data. And so, as we're talking with the employer groups, they want to see data in self-insured employed groups, not in dissimilar populations of patients. And speaking of the self-insured employer group population, one of the other insights we learned is that while we have a lot of evidence looking at the impact of CMM on all aspects of the quadruple aim, we don't necessarily have robust evidence in every type of population. For example, self-insured employer groups. We don't have a lot of contemporary data looking specifically at CMM services and the impact on an employed population. Next slide. We were able to focus our efforts. We prioritized self-insured employers and patient consumer advocacy groups for our first round of marketing content development. The tools that we've developed that were shared with you in the pre-reading materials are both focused on self-insured employer groups. One is an FAQs document. This was developed based on actual questions asked by our employer group, and we attempted to provide succinct but heavily referenced answers so that someone could get the gist of the answer quickly, but then look to the references if desired to get a deeper understanding. The second tool is an infographic that really kind of lays out what the problem with non-optimized medications is in terms of cost, financial and cost in patient lives and employee productivity, and then outlines the intervention of comprehensive medication management and other medication optimization strategies and the impact of those on outcomes of interest to self-insured employer groups in self-insured employed populations. So we did look to find data specifically to populations that they would find similarity with. And then the final section is a call to action for self-insured employers to demand that comprehensive medication management services be offered within their health or pharmacy benefits. We envision these tools being used either alone or in combination with use cases that are relevant to the population of interest, as well as literature summaries from our evidence-based resources groups to create a head start on a business case or a comprehensive marketing package, if you will. Next slide. Moving forward, we're going to continue to expand upon our patient consumer advocacy focus. We have a near final draft of an infographic for a patient consumer advocacy audience. We hope to turn that ultimately into a web-based dynamic tool that will have video testimonials attached. And now we've also started to work on marketing content for other stakeholder groups, in particular physician practitioner audience and ACO population health focused stakeholder groups. And ultimately, as Julie said, we hope to merge these marketing materials with the use cases and relevant literature summaries to create comprehensive resources for those interested in sort of getting buy-in from a C-suite or whatever stakeholder you're going to. That concludes my remarks, and I'll turn it over to Katie Capps to lead our Q&A.
Katie, you're on mute.
Thank you, Julie and Amy. And those of you on the line with us can see how hard our work groups have been working and such useful guidance that they have produced just over the past 6 months since we released our Blueprint for Change. It's remarkable. And we are very much looking forward to getting these out for broad use. You can also see how mindful these groups are of the importance of ensuring that education occurs on the demand side, which is consumer groups, employers as health plan sponsors, and the medical carriers, and on the supply side, which would be physicians, prescribers, clinical pharmacists, and other team members. They've certainly been mindful of the importance of not only educating those groups, but also informing them of the literature, the peer-reviewed evidence that's available, and the importance of fidelity of practice, as was mentioned earlier. So these are the questions we have for you, our audience, and we encourage you to respond back in the chat box, answering to Q1, Q2, and Q3. In the meantime, I'm going to ask some questions of our presenters while you are responding to these in the chat box. If you have additional questions that you would like us to pose to our presenters, please submit those as well. Julie, I'm going to throw this out to you and Amy. It's a question that came in earlier from the group. It's really more geared toward the outreach efforts that Julie, you and Amy are looking at, and that is how is the entry of Amazon CVS Aetna merger, how will that impact from your standpoint the delivery of CMM services or access to CMM level services? Do you want to take a run at that question?
Well, I'll give it a try. Well, you know, I think anything that brings a pharmacist closer to its patient is a great item. And time will tell really how these programs are embodying many of the principles of CMM practice beyond simply dispensing the medications, right? But we hope that they will definitely be able to encompass many of the identifying medication-related issues, communicating directly with the patient related to compliance and adherence, and really taking a keen look at what types of medications the patient is taking, and then individualize working with that patient and the healthcare team to try to optimize their medications.
Thank you. And with that, we have a follow-up question somewhat related to that, and that is how do we determine which pharmacists are qualified to actually provide CMM level service?
Well, I think as I read the question, I'll take a first stab, Julie. I think as I read the question, credentialing was one thing that was suggested. I think that could certainly be one method of identifying competence in providing comprehensive medication management. I think there are other potential standards to think about, such as board certification, residency training, or equivalent experience. If a person has equivalent experience and could sit for the board certification exam, they are likely ready and able to provide comprehensive medication management services. I think in a lot of institutions, the credentialing for that particular institution or the credentialing for a health plan, these things could be factored in, but might be unique to the region perhaps, or to the particular plan or health system.
Thank you, Amy. And I think we've seen a lot of misunderstanding about certain definitions, and this has certainly been pointed out through many of our guidance documents in terms of defining MTM, defining CMM. Interestingly enough, and Amy, you and Julie have been very good in terms of tracking and participating in and responding back to our employer toolkit task force, which is comprised of 10 of the country's largest business coalitions nationwide. Interestingly enough, they released the National Alliance, which is their roll-up organization, released a survey recently, and some of the findings of that survey were covered in a webinar that the Institute hosted last week that said that 49% of employers basically use MTM, or medication therapy management, to manage drug costs. There are a lot of misperceptions about what MTM is and what CMM is and isn't. And I think your goal with the infographic that you created was to clearly define what employers as health plan sponsors should look for when they look for CMM level services. Is there anything you'd like to comment on, Julie or Amy, as it relates to those misperceptions or misunderstanding about those terms?
I can start with this one, Julie. To be honest, our work groups have had hours of conversation around this because certainly there are differences between the typical Part D, Medicare Part D MTM services that are often delivered and a true comprehensive medication management with Fidelity service. However, there are also, there's a lot of valuable services being offered around medication management that aren't comprehensive medication management. So I think one of the key things in terms of what we've been discussing is that all of these services are valuable, and many of these services lead to improved outcomes. But we believe the important thing about comprehensive medication management is something Sean said earlier, where we're able to compare apples to apples and ensure that this specific intervention has these specific outcomes. So our focus on comprehensive medication management has been simply to make sure that we're putting together evidence and literature and infographics and marketing materials, all that relate back to this particular intervention at improving medication optimization. And that's not to suggest that other services around medication management aren't valuable. That's just not what we're focusing these things on, because we want to bring this kind of robust and apples to apples approach to it. The other thing that I'll just end with is that, as Julie said, as she was starting her remarks, there's issues around this terminology. So a lot of services that are in fact meeting the operational and essential functions of comprehensive medication management call themselves medication therapy management. So I think it's more important to look at what are the steps and the operational definitions in the intervention being delivered versus focusing on what is someone calling the intervention that's being delivered. So it's really complicated, and I hope we can get to a point as this matures that we're all calling CMM the same thing, and that we're only calling that intervention CMM when it is CMM.
Yeah, I think the challenge is how comprehensive is your medication therapy management program? Right.
Yes, so, and is there follow-up involved?
Right,
which I think is another kind of key missing element sometimes.
Right. So, Julie, another question to you: what additional use cases is your group seeking to showcase real-world evidence on use and success of CMM in practice? Because we've gotten a couple of comments saying you're right on track in terms of producing the type materials that are needed. But what are some additional use cases that your group is seeking to showcase?
Well, some of these are surrounded around different stakeholder packages. So our group is exploring 2 additional stakeholder packages, one that focuses on physician practitioners, and how the pharmacist contributing to the team improves not only provider satisfaction, but really unburdens the provider, whether it be a primary care provider or specialty care provider, to have more time to address some of the urgent or emergent patient care issues, because the comprehensive medication management is being performed by other team members.
Mm-hmm.
So we are in the process of identifying some of the use cases from the evidence-based research group listing that we have already that the evidence-based research group has already put together. The other thing that we're looking at, and it sort of relates to your last question, is how does the consumer, how does the patient know how to access the pharmacist?
Mm-hmm.
And is the pharmacist available as a resource, as a part of the healthcare team? And as you know, there's many different types of pharmacists that practice across the country. So what are those parameters that are in place so that that pharmacist or that caregiver knows how to connect? And so those are some of the things that we are looking at with the patient consumer advocacy groups. I think there was a question on the chat related to social determinants of health.
Right.
And so when you think about that, it helps us to sort of look at, we've already are looking at some of those high-risk patient populations. And some of those patient populations are in rural areas.
Mm-hmm.
Or underserved areas. It might be a very metropolitan area. So trying to expand our use cases into those sort of scenarios to describe how that patient knows who their pharmacist is.
Right, and what to expect during the CMM process of care. I think that's another important component too. It's not a discrete activity, as you and Amy have mentioned. It's iterative, there's follow-up, there are also other activities that occur. What are those actual activities that, in the hearts and minds of consumers, they should expect? What are the activities that the interprofessional team should deliver? And likewise, I think those are some of the questions that we've received. For those of you on the line that may not know, we convened that group of large national employers over a 12-week period, and Julie and Amy and their work group were very responsive to the multiple questions that they had. And as a result of that, created that frequently asked question document. But how do we know it when we see it? What do we contract for? And when we're measuring or evaluating it, what are the things we need to look for to hold our vendors, the medical carrier, possibly the PBM, accountable and responsible for? So, Amy, the next question to you. Your group produced that frequently asked question document that I mentioned for employers. What's the biggest takeaway from that guidance document that this group needs to be aware of from your standpoint?
Well, I mean, I said it earlier, but it really was kind of a big aha for us, I think, that in talking with these self-insured employer groups, two things, I guess. One is they want to see outcomes in a self-insured employed population. Mm-hmm. So if I show them a use case from a non-employee population, they're like, well, that's really impressive, but I'm not sure that would really relate to me because I have, working age individuals, and that group has a lot of geriatrics in it. And, so I think the desire to see outcomes in their own population or a population very similar to their own was definitely one big takeaway. And the other was just that that kind of call to action piece of the infographic. So a lot of times, in my experience, you're kind of selling it. But then what happens when the person goes, I get it, I agree, I think this is what we should do. Now what should I do about it?
Right.
And we have to be able to kind of help guide them to what we're asking of them. What is the ask?
Right. And your group certainly has a real challenge because you have to translate what you know is occurring at the practice level into buyers' demands or purchasers' demands. And that's not always easy because that's a translation process. You have to translate it into what the current vehicles are in which to demand that service. So,
Yeah.
Julie, with that, and as a follow-up to Amy's response, why are employers and health plan sponsors important to the work of the Institute and the work of your work group?
Well, there are strategic partners. When we think about our health plan sponsors, they help us to identify gaps that they are facing. And I think GTMRX and our work groups can help them with the solutions and how CMM can be an answer to their gap. And trying to describe all of those different things and pull them together is really powerful. So, I hope that we will continue to be able to work with our different plan sponsors and stakeholders to identify exactly what they need, and then we can translate it into how they can do it.
Thank you.
And improve patient care for our patients.
Absolutely, and ensure appropriate use of medications. So, the final question, Amy, is to you. You mentioned this, and Julie mentioned this too. Building consumer demand is important to ensure that the healthcare systems are responsive to the consumer and caregiver needs. It's not just the consumer; it's the caregivers of those consumers as well, or the patients. By offering CMM in practice, what's the biggest takeaway you can offer about the complexity of educating consumer groups about the importance of CMM in practice? I mean, why should it matter to them?
Mm-hmm. Well, before I get to the why should it matter, I mean, what you just said about the caregivers has been a real focus of our early discussions about how to focus this content. Because we know that it's often the patient's daughter or their niece or their nephew or their, spouse that is seeking out and trying to find the best patient care services and information for their loved one. And so when we talk about a web-based dynamic tool, we're really kind of targeting that group of caregivers, the helpers in their families and so forth. But it is complex because, if you looked at our participants in our work group and really across all GTMRX work groups, there's a lot of scientists. We're all clinicians and scientists, and we are data driven, and we look at the evidence and we talk about statistics. But patients and consumers care less about that. They care about how their actual experience and how something feels. And so kind of trying to translate, as you said, again, using your translation word, translate what we know to be true and the evidence and the data into compelling emotional stories that patients and their caregivers can relate to. I think that's what makes it very complex.
Well, thank you. And unfortunately, we come to the end of the session. So on behalf of the Get the Medications Right Institute, I want to thank all of our presenters today. I also want to thank the leadership of the Practice and Care Delivery Transformation Work Group and subgroups, many of those represented through the speaker presentations today. This wraps up our 4-part membership feedback series. Your insights have been incredibly valuable to the Institute and to the leaders of the work groups within the Institute. After this event, you will receive a survey. If you've not already received it in your mailbox, please fill out that survey. That's additional feedback that you can offer back to the work group leadership as we work to advance access to appropriate medications for all Americans. I also invite you to visit the GTMRX website and download our latest report, which is the Blueprint for Change. The resources and tools discussed in today's presentations will be available soon in our resource center. We will start distributing those tools right away. Please join us on Facebook, LinkedIn, and Twitter. And please share broadly the guidance documents that we will be releasing over the coming weeks. Thank you for joining us today and have a wonderful day. Until next time, be well.